Hello, listeners. We want to let you know that we will be presenting at the Pennsylvania Society of Addiction Medicine annual meeting online on March 2nd. You can hear us speak and even see what we look like.
After an extensively heated discussion, Sonya and I have picked the 10 articles that we reviewed which changed our practice the most.
It's a little embarrassing, but we're going to put ourselves out there and tell you some of the things that we did wrong and how we changed our ways after reading these 10 articles.
You can register for the conference at psam-asam.org.
Hope to see you all there. This is Addiction Medicine Journal Club. I'm Dr. Sonya del Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This episode is a little bit different. We just came back from the ASAM conference, and we wanted to share with all our listeners what we learned. John, how are you doing this evening?
I'm doing great. I'm really kind of excited to kind of switch it up with a new format and a kind of a little bit different style tonight for tonight's episode.
Yeah, me too. Before we talk about any specific sessions, what did you think of the conference in general?
I thought the conference was really interesting. I think there was a lot of networking opportunities. I will give a shout out to ASAM because I actually thought the food was really good overall. The lunches were fantastic and they were pretty healthy, like salads and chicken. And I thought it was really nice. And I really kind of enjoyed not only the conference material, but it's really nice to have, there's a lot of networking sessions and opportunities to talk with other people in the field. And I think that actually was some of the best conversation and learning I had was just sharing thoughts with other people that do this every day.
Do you remember that poor addiction psychiatrist at breakfast who we forced to give an impromptu seminar on ADHD? That was pretty fun.
That was fantastic, actually.
I also really enjoyed just meeting all the different addiction medicine people from all over. You know, you and I both practice in an area without a lot of official addiction medicine providers. And so sometimes we feel a little lonely. And, you know, in our health system, in our area, we're both considered a little bit radical. You know, we're on the fringes a little bit, but then we come to the ASAM conference and we see all the amazing work people are doing. And we realize we're actually very conservative and kind of tentative in what we do. It's just what we do is just a drop in the bucket of what could be done, what work there is to do. And so I came away with a ton of ideas about how to just take it to the next level and all the different things people are doing out there to help treat patients with addiction.
Yeah, I think it was kind of humbling because you're right. I think in our organization, people kind of view us as kind of like having this group of people that's very difficult to treat at times. And I think they view some of the treatment and some of the laxity that we give these patients kind of meeting where they're at as kind of like, you know, been called enabling before, but I don't think that's what it is. I think that there's just a lot of barriers to care for these patients that you have to be flexible with. But then I hear what they're doing at other places and they make me feel like I'm a Boy Scout. So I thought it was really cool just hearing everything that's going on and how successful a lot of this stuff is. And especially with regards to harm reduction, how a lot of the things that are harm reduction, they really do benefit the patient. And maybe we shouldn't view them as being something to kind of avoid or like a treatment kind of compromise as maybe kind of a good endpoint, actually.
Yeah, that's a great point. I also wanted to give a shout out to the Curbsiders Addiction Medicine team. We started the conference outright by having a podcast breakfast with them. And I was really excited to meet them and they were super nice. So if you haven't listened to the Curbsiders Addiction Medicine series, we definitely recommend it. And guys, it was very fun to meet you at the conference.
So the one thing that the conference started out with an opening general session called The Science of Happiness by Jillian Mandich. And, you know, these kind of like resiliency or like happiness sessions, I think it was a good way to start the conference. Sometimes I think people are a little resilient to these ideas, but they were just talking about what actually is the scientific data behind people that are happy. Some kind of takeaway points is that, you know, there's well-validated data that people that are happier, they have less kind of common colds, less rhinovirus exposure. They do better at work, increase income, increase promotions, increase performance, decrease medical errors. And they really talked about kind of like the big three foundational things in happiness research that always kind of pan out. So these are the three pillars of being happy at your job. Nutrition, adequate sleep, and physical activity, with physical activity notably being the most immediate to kind of give you improvement. Other takeaway points is that people that are the happiest tend to have small, frequent bursts of happiness. So instead of kind of shooting for grand gestures or for things like large trips or large ticket items at your house, you should be shooting for more frequent little things like maybe dinner out with your spouse or significant other, going to a baseball game with your kid. So I think that those were really kind of interesting things that I'll take away. They also talked about how there's a thing called hedonic boost, where when we get something new or we do something new, that it makes us happy only for a short period of time, but we become kind of immune to that as the exposure continues. So that if we want to kind of continue to stay happy, really things we need to do are a variety of things to make us happy, frequent surprises, and really kind of appreciating what's going on around us, which I think most of us always focus on the negative things. So just some food for thought. Probably not the most hardcore science of the sessions we went to, but a few pearls to take away if you're struggling to be happy at your job.
That's awesome. Thank you. After that, we both went to a talk called Advanced Buprenorphine Initiation Techniques by Doctors Melissa Weimer, Andrew Herring, and Laura Kehoe. Sorry if I mispronounced your names, doctors. This session definitely, things got feisty. So with fentanyl now being the most commonly used illicit opiate, older protocols for initiating buprenorphine sometimes don't work for patients. And different doctors are trying all kinds of different things to get people safely onto buprenorphine. They talked about high dose starts and low dose starts. I personally would have been comfortable with the high dose initiation protocols they discussed. The low dose protocols where you overlap the buprenorphine with the full opioid agonist, I don't think I'm ready quite to recommend that in my outpatient practice. It's a little much for me to be recommending patients continue to use illicit fentanyl along with buprenorphine, starting to prescribe it. And I totally understand how if a patient truly cannot stop using the fentanyl, even for the 2 or 3 days needed to start the buprenorphine, how this is a method that can get around that. But I just don't know if I'm comfortable recommending it officially. But the high dose protocols seem like they really could work for some of my patients. So as the speakers presented it, basically you do the same thing we normally do, which is you stop your full opioid agonist, your fentanyl or your prescribed opiates. You wait for your withdrawal to start. And then when the patient reaches a COWS score of over 12, meaning moderate to severe withdrawal, you start your buprenorphine. But rather than start with a low dose like 2 milligrams or 4 milligrams, just start with a high dose, start with 8 milligrams. And then in a few hours, another 8, all the way up to 32 milligrams on that first day. The presenters had said that our initial starting dose, which is normally 2 to 4 milligrams, can cause precipitated withdrawal because it's high enough to provide a significant antagonist effect, but not high enough quite to provide a significant agonist effect. So you get the withdrawal, but you don't get any agonism to counteract it. And patients can have pretty bad precipitated withdrawal with that initial dose. So that definitely gave me something to think about. What did you think of that talk?
I thought the talk was awesome. It's actually interesting what you said, because actually I kind of used this talk to give me the confidence to I did my first low dose buprenorphine initiation last week. And it was a patient that has come to my clinic multiple times, unable to stop. And I said, well, let's just try this. And I gave him a very, very small dose tablet that he broke into very small pieces, approximately half a milligram, and actually worked fine. Now, his use was not super high, but it was something that I would never have done even before this, even though I've heard about it. So it kind of gave me confidence to put that into my wheelhouse. I thought another really good takeaway point from this was they talked about people that were using these low dose buprenorphine initiations actually not using sublingual, actually having patients swallow dissolved buprenorphine. So I did not know that the bioavailability of oral buprenorphine that's swallowed is 40%. So they were talking about dissolving a partial tablet into like 8 ounces of water and having the patient drink that as part of the low dose initiation protocol. So I think that's definitely a bullet point to take away in your toolbox.
Yeah, that's cool. For the low dose initiation start you did you give the patient a handout or just describe the method?
I just described the method.
Well, good for you and good for your patient. That's cool.
The next talk, we kind of broke away and did separate things. And the one I went to is called Wounds, Withdrawal, and Overdose, What to Expect from Xylazine Drug Supply Adulteration. And this was by a panel of toxicologists by Joseph D'Orazio, Rachel Whiteman, Evan Schwartz, and Jean-Marie Peroni. And I thought this was interesting, mostly because our hospital is located kind of very close to Philadelphia, where this is really kind of a prime issue. So just a little background, xylazine, it's an FDA alpha-2 agonist. It's used in veterinary medicine for sedation. It's not FDA approved for humans because it was causing too much of a blood pressure reduction. So you can only use it for veterinary medicine, but you can buy it online from China and it can be shipped to you. So I thought that was relatively interesting. It's really an East Coast problem. Predominantly Philadelphia is kind of geographically the most common area, with 90% of the supply in Philadelphia currently contaminated with it. It is found in other parts of the country, but it really is not found in that frequency as it is in the Northeast. So it's really kind of mostly a Northeast issue. It's interesting because unlike most adulterants, xylazine is actually a very large portion of the drug supply. It's used as a cutting agent, and they use large volumes of it to kind of dilute fentanyl. So that kind of goes into a lot of the data that comes out regarding kind of co-ingestion with xylazine. It's really tough because there's no rapid tests. The detection window is incredibly narrow. So a lot of times they're empirically treating people for presumed xylazine co-administration based upon symptoms and supply in that area, not based upon any testing. Some interesting points about kind of people that have presented with kind of overdose or in withdrawal with this medication is that xylazine patients often have higher CAL scores at the time of presentation. Not only that, they're more likely to leave the hospital AMA, so less likely to stay for treatment. There was studies showing that, like we said earlier, that while xylazine is such a large component of the drug supply, so it's a large volume of the cutting agent used, that because of that, actually overdose risk is less with it, mostly because patients are getting less fentanyl or less opioid. Surprisingly, not only that, patients actively don't want this in their drug supply. So they did kind of this social media study, and patients were actually trying to find drug supply without xylazine because they don't enjoy the experience. They were very sedated. A lot of times the report is that they never got high. So basically they take the medicine, they pass out, and then they're no longer high when they wake up. So it's too much of a sedative for them to typically enjoy. Interestingly, there was a lot of discussion about, does xylazine withdrawal really exist from the toxicologist? So the thought about it is like that really kind of the symptoms are kind of so nonspecific, mostly like anxiety, dysphoria, restlessness, but really not kind of autonomic instability. So they're saying, is it like a true withdrawal syndrome or not? And that was a little bit of a debate by the panel. So I thought that was interesting to hear. Treatment's pretty supportive. So mostly things like clonidine, which we use for withdrawal anyway, since that would kind of replace the alpha-2 antagonist. Precedex, dexmedetomidine, which also we use that all the time in ICU medicine. That can be another substitute out for acute withdrawal. Interestingly, naloxone is not needed except for the fentanyl component or the opioid co-ingestion. The other part of it was about the wounds associated with xylazine, and a couple of things as well. It's even though the supply is found kind of geographically distributed throughout the United States, the wounds are really kind of a Northeast phenomenon as well, most concentrated in the Philadelphia area, even kind of the same supply across the river in New Jersey. They're saying not so much in terms of the wounds that you see in Philadelphia. Some characteristics of the wounds are that the pain is not proportional to the wound. So the wound looks terrible, but actually the patient's really not that discomforted by the wound. They don't understand the mechanism. There's thought, could it be like cytotoxic? Could it be vasoconstriction? Could it be due to skin pricking? Although there is some cases where actually kind of non-injection wounds develop. So people kind of inject or they inhale and the wounds develop at alternative sites. So it's not even injection sites that develop these areas. So all very, very interesting. I don't know. I think just one more understanding of a very common co-ingested material for our patients, unfortunately.
Yeah, I've seen one patient with weird wounds that I presumed were xylazine related, but I had no confirmation of that. All right. I went to a talk after that by Dr. Sarah Spencer. It was an amazing talk. It was called Utilizing Low Threshold Extended Release Buprenorphine to Address Stimulant Fentanyl Overdose Risk in Rural Alaska. And I loved her talk about how to use extended release buprenorphine, which is brand name Sublocade. It's an injection that lasts for 28 days. And instead of having to take a daily pill or film of buprenorphine, but I was most interested in her description of her setting. So she's in a rural Alaskan community where not only do some patients not have, say, great access to physicians, they don't have access to pharmacies, and they don't have access to transportation at all, like no roads available. And so people will get their medication by mail drop, which might come 2 or 3 times a week, but not if the weather is bad. Patients may not be able to travel to the clinic at all, again, based on weather. she tries to get people in, but it's just often completely impossible. Some people come by boat or by plane to see her in her clinic. And it was just really cool to hear about all the ways that they work with patients with these barriers in place. So I learned that sometimes she gives the extended release buprenorphine injection without the 7 days of sublingual buprenorphine first. She did say she tries to get people through 7 days of sublingual bup before their first injection, but given the logistical hurdles some of her patients face, that's not always really possible. And she had had success giving the initial injection right off the bat once the patient had started to experience significant opiate withdrawal, and using additional sublingual buprenorphine to help combat any of the precipitated withdrawal that might pop up when the patient gets the initial injection. She also had some people, who didn't make it the full 7 days, but took sublingual buprenorphine for just, 3 or 4 days and then got the injection, and they had all done really well. The audience was pretty feisty in that session as well. Tons of questions. And I didn't get to tell her personally how much I enjoyed her talk, but if you're listening, Dr. Spencer, keep up the good work. It was pretty awesome.
The next one that we went together, it was a general session. So this was like at ASAM, it's not just physicians, it's also people that are involved with public policy, social work, care coordination, also kind of recovery support. It was about compassionate approaches in the criminal legal system. And it was like this tag team presentation by Justin Burke, Regina LaBelle, Jessica Maraglia, and Terrence Walton. And I felt like it was a great talk. It almost kind of like pumped everyone up. A lot of the message that they were giving us, that's everyone in the room is a very receptive audience to this. So it's basically talking about how treatment programs work and how intensive supervision treatment programs, how like the data shows that there's at least a 21.9% decreased risk of recidivism, which is better than a lot of our other classic treatment outcomes. Very sadly, they talked about that currently greater than half of patients with opioid use disorder that die of an overdose while engaged in the criminal justice system. So they're either pending court cases, they're pending arraignment, or they're actually in prison. So that, that's kind of a somewhat, I hate the word captive, but we do have an engaged audience that you could really kind of trigger into treatment. And with half of the people that are dying actually being involved with this system, kind of linking care into the system seems like that would make the most sense. Very impressively, initiation of medications for opioid use disorder while in prison are associated with a 61% decreased risk in post-release overdose deaths with a number needed to treat of 11. So that's another great reason to treat. And then they talked about something which makes sense, but I've never heard of a name for it, but they call it recovery capital disruption. So patients that are incarcerated, they lose things like employment, housing, food stamps, sometimes even health insurance benefits. So that basically disrupts their active treatment plan. And because of that, 10% of patients that are in incarceration actually drop out of treatment and kind of relapse back to drug use at least. So all kind of more reasons for why drug court and kind of treatment court really works. I was really inspired by Jessica Maraglia's talk about her own kind of troubles where she grew up with issues with substance use disorder. She kind of overcame them, worked full time as a mother, went back to school, went back to law school, took her bar, passed her bar, and then was determined to not be a person of good, quote, moral character because of her substance use history that was in the past many years. And she had to challenge to get basically to become a member of the bar in Pennsylvania. Now she actually runs the treatment court, which I think was really cool. So it was a really kind of positive, uplifting story about how like treatment works. And it kind of makes you just feel good, just showing you what people can do if they're given the right opportunities.
It was very inspiring. She's done a lot of amazing things.
I think the best part was that the DA that prosecuted her is now her assistant DA, which she was like a decade before. I think that was the right story that she said. But basically, the person that was prosecuting her is now reports to her, which I think is kind of ironic. But I'm sure that he's a nice guy too.
I went to a session on my own called Substance Use, Social Media, and Technology by Dr. Amira Athanasian, and you should follow her on Instagram. I have to say that because it was a social media talk. And two other people, Craig Perry and James Shearer. So I don't want to spend too much time on this, but I did have one really interesting takeaway, which is that you should consider social media for your patients as a form of peer support. I suppose this would be obvious, but I don't actually use social media that much. I use it to promote the podcast and talk about addiction, but I don't use it for my own social life. And thinking about it as peer support reframed how I view my patients' use of social media. So when you're thinking of a patient using social media as part of their recovery, you have to think about it as part of a peer support network with all the pluses and minuses that come with that. They gave some tips for making the social media experience a positive part of recovery. And mainly it was that you have to use social media consciously, picking people and accounts to follow that are positive, that promote your recovery, and not engaging, blocking, unfollowing all those accounts that are negative and have a negative influence on you. And if you do that consistently, then the social media algorithm will serve you up positive content that helps your recovery. And your patients should include social media in the people, places, and things that they are trying to avoid when they're trying to avoid relapse to substance use. They should make sure that their social media also is free of people, places, and things that might trigger relapse. And that a lot of patients do get a lot of positive social support off social media. So nothing too profound, but I hadn't thought about it that way in the past.
The next talk that we went to together, and I'm sure we have a little bit to talk on this one because it was really good, was Buprenorphine for Pain, an evidence-based practical approach by Lee Radish. I think when I first was going to go listen to this one, I felt it was a little triggering because I often feel that people with pain want to get on Suboxone or buprenorphine for kind of pain-related reasons. And I will be honest with you, in the past, I've had great success. So I wanted to see kind of what tips, tricks, and things we could do to kind of maybe kill two birds with one stone. And I want to use some brand names here too, just so you guys know about the different products that are available. But essentially, there are 3 FDA-approved products for pain. They're all buprenorphine. They come in patch, buccal, and then IV or IM form. And Butrans is the patch, Belbuca is the buccal formulation, and Buprenex is the IM and IV formulation. And those are FDA-approved for pain. Suboxone, Subutex, and Sublocade, they're FDA approved for opioid use disorder, but they can be used off-label for pain. They did talk about kind of when you code these, most of the time pain and kind of opioid use disorder will be co-occurring. There's probably not many patients that have true just opioid use disorder without a pain generator, so it's probably not fraud to use it one versus the other. The formulations for pain are about 1/10 that of what we use for opioid use disorder. And that just has to do with the saturation of the opioid receptors that you need for the craving component.
I want to add one thing, though, that just like you said, I was surprised to learn that the sublingual formulations and the Sublocade, the injectable formulation, get you to 10 times the blood level of the patches and the formulations that are approved to pain. But he did point out that having that higher blood level didn't necessarily correlate with better pain control or better analgesia, because the whole buprenorphine for pain research is still pretty young. So
that's a great point. As you know, anyone that prescribes, there is a ceiling effect of buprenorphine for respiratory suppression, and there's a questionable ceiling effect for analgesic effect. So they're saying that, you can kind of go beyond that 16 or 24 milligrams if you feel the clinical situation is appropriate for kind of additional analgesia. Whether or not that there's data for that, I think that's debatable, as Sonya was just saying. Other kind of important updates that I thought were notable is that the FDA is actually considering adding a warning to all opioids of the effect of hyperalgesia. So I think most of us that prescribe opioids for chronic pain know that the hyperalgesia that people get with opioids is really difficult because people will perceive that their pain is out of control when probably their pain is related to opioid-induced hyperalgesia. And really it's kind of non-painful stimuli that are resulting in pain. I do think that kind of if patients were aware that that is something that they could experience, that might make them less likely to want to use that as a pain management strategy. And they also talked about how the VA and the Department of Defense have actually updated their chronic pain management guidelines for chronic pain, recommending actually buprenorphine as a first-line agent for kind of chronic opioid therapy if you're considering an opioid for pain, mostly due to the improvement of respiratory suppression that you see with this compared to other opioids and the safety of it.
Yeah, I mentioned those new VA Department of Defense guidelines at a talk I gave a few weeks ago for the Society of Hospital Medicine, our local chapter. And when I said that, I saw a bunch of people, bring out their phones and snap pictures of the slide. That was new information for a lot of people, that the VA actually recommends buprenorphine as first line. if you're going to use an opioid for pain.
The other takeaway point, and this is like the big one, is that if you're using buprenorphine for pain, really you need to be splitting the dose more so than typically what we do for opioid use disorder. So for opioid use disorder, you're doing daily or BID dosing. If you're using it for pain, they really say splitting it to a TID or QID dosing is really probably going to get you the most likely analgesic effects. What did you take away from that besides those points, Sonya?
The one thing I might change was my dosing of buprenorphine for pain. The speaker said he uses 4 milligrams 3 times a day when he's dosing buprenorphine for pain. I've been using 2 milligrams 3 times a day, but I'm almost always doing it in patients who are on buprenorphine at baseline, usually at least 16 milligrams. So giving them I usually give them an extra 8 split into 2 milligram doses up to 4 times a day. And I realize that might not be enough. So if I have someone who's really not controlled on the 2 milligrams, I'll be more comfortable bumping it up to 4 milligrams 3 or 4 times a day for pain or for the duration of their painful condition. I think also I'll be more comfortable using buprenorphine as first line for pain. I think the patch and the buccal formulations that are approved for pain are expensive and not necessarily covered by insurance. And then the sublingual formulations are only covered really for opioid use disorder. But as you said, the speaker said you could put opioid dependence as your code, which is true for most patients who are on chronic opioids. They do have opioid dependence. It's pharmacologic. And if you're transitioning them to buprenorphine, that's an acceptable ICD-10 code that would get it covered. He did make the good point, though, that there's a lot of stigma with these medications. And so patients may not want that medication on their problem list or their medication list in their electronic medical record. They'll feel it marks them as someone with opioid use disorder, and they might not want that. So you have to really discuss that with the patient before you would start prescribing, at least right now.
It is interesting, the stigma. I had kind of just anecdotally a patient this past week that was having some refill early requests and then, didn't show up for a UDS pill count. And then, got COVID for the 4th time for the makeup UDS pill count. And then finally stated that, they had a problem with their opioids. And I was like, well, that's really great that you could tell me that. I want to help you. And we talked about doing buprenorphine. And it's interesting. She came from a pain clinic, so that wasn't an option to her. She felt like there was a lot of stigma with that, and she didn't want any interest in that whatsoever.
It's interesting to me how patients feel. Some embrace the public recovery persona where they are happy to tell everyone they're in recovery and it's part of their core identity, whereas other people really keep it close to the breast. They feel it's not something that they want to share widely. And I don't think one strategy is better or worse, but I can see a lot of patients not wanting to be marked with a buprenorphine prescription. Next, we both went to the Updates in Addiction Medicine, which is an annual review of addiction medicine. And I think they do it every year. It's by Drs. Sarah Wakeman and Joshua Lee. We felt pretty good that we had profiled some of the articles that they had mentioned, thus validating our article choices. The speakers feel that the number one update for the year is psilocybin for alcohol use disorder. It was certainly the most popular article in addiction medicine this year. It got a ton of press. We covered it in our podcast as well. However, I was a little disappointed because I don't think it was an update that will actually change clinical practice. I mean, it might be in the future when we're all prescribing psilocybin for alcohol use disorder, which may be someday, but right now it's not really available for general practice. It's an experimental protocol, and your run-of-the-mill addiction doc like you or I can't really use it at this time. So they did do an update that will have an impact on day-to-day practice. It was another big update for the year, is new data on the risks of alcohol. So there have been several new meta-analyses and new data that came out over the year showing that alcohol has really no safe level, that any drinking is a health hazard, especially cardiovascular hazard, but also carcinogen. And already around the world, national practice guidelines are changing to reflect this new data. Although the US has not changed its guidelines yet, some other large countries have to say that no level of alcohol is good for you. So what did you think of the updates, John?
I thought it was good. They did 20 articles when I counted up, and at least that's the ones I caught. They were going so fast. And it was interesting. They were very scientific about how they picked these. They basically gave an impact score based upon how often the article was referenced, viewed, and read. So it was some kind of objective data there. It wasn't just subjectively. The big thing was out of the 20 articles, it came into 5 themes, like overarching themes. The first was psychedelics. So as we talked about before, the psilocybin-associated psychotherapy, also ketamine for alcohol use disorder. That was kind of a lead because there's a lot of interest in that. A lot of people were reading those articles this past year. Although I do agree with you, I don't think they're ready for prime time for the average physician just yet. The second theme was basically how COVID was bad for anyone with a substance use disorder. There was like 7 or 8 articles showing that increasing overdose rates amongst people of color, increasing overdose rates among adolescents, with actually a third of those that overdose not even having a diagnosis of opioid use disorder, 25.5% increase in alcohol use disorder deaths, increased severity of liver disease over COVID, increased tobacco sales, increased telehealth access being a possible way of mitigating some of these issues in terms of treatment or delays in treatment for people. That was the second bucket of articles. The third really goes into zero alcohol is healthy. And there was multiple articles about how basically there is no safe amount. And there was one article that stratified people based upon age, geography, sex, and at what point in your life was it okay to drink, or what point was it healthy? And it showed you that probably older people were the healthiest because they're going to die anyway, not because it was healthy for you as you got older, just that, your chance of death was higher. So at 84, if you want to have the beer, it's going to have less impact on you than a 23-year-old. The fourth theme was cannabis for pain and opioid use disorder, talking about rising rates of THC found in people after motor vehicle collisions, mostly kind of white older men. So not a great representation for a lot of people. How it can be useful for neuropathy, although the side effect of dizziness almost negates how much pain relief you get from THC use. And then the last group of articles is all just basically specialty articles that were kind of like almost like a hodgepodge. And one was about e-cigarettes probably being more effective than nicotine replacement for smoking cessation. And the most interesting one I saw was people that get an alcohol home delivery service probably have an alcohol use disorder of some point. I thought that was a very interesting article because people talk about that. Just like people that do dry January, we've covered before, have higher rates of kind of unhealthy relationships with alcohol. So I think when patients tell me that, probably I'm going to maybe explore that a little bit more to see if there's more going on at that visit than they want to initially kind of talk about.
That's an awesome summary.
Sorry, I didn't do it justice. There was just so much for that one.
Yeah, that was a really dense talk, and I will look forward to going to it again next time I go to ASAM. I think they do it every year, or if they don't, they definitely should do it every year. It did point a little bit to some of the different attitudes about addiction medicine that we saw at the conference. I felt like half the addiction doctors were the dude at the party standing near the bar, kind of saying, all alcohol is unsafe. You shouldn't drink at all. The guy no one wants to invite. So half of us are doing that. And the other half of us are like microdosing ketamine and psychedelics and using all kinds of wacky medications, psychotropic and possibly addictive medications to try to help our patients. So all these articles point out the sort of two different sides of addiction medicine. I'm not sure there are other fields that have that kind of strong dichotomy in them. So the last talk I went to, and you went to it also, the final day of the conference, or the last talk I want to talk about, was called The Secret Life of the Illicit Drug Supply in the United States. It was by 4 toxicologists, Dr. Stephanie Weiss, Jeffrey Brent, Joanne Lees, and Lewis Nelson. They talked about how to get information about novel psychoactive substances. So they shared with the audience a bunch of resources that you could use to understand which drugs are being used, where and when, and why some information is available and other information is not available. So I learned about a bunch of resources, and I'm going to put them in the show notes. My favorite was drugsdata.org, which is an anonymous laboratory analysis and drug checking center. So you can send them samples of your drugs, and they will send you back a report on what it was actually that you sent them. You don't get your drugs back, though, they said, because it's illegal to send drugs through the mail. And the presenter said it's legal to send the drugs to the lab because technically you don't know that it's drugs because that's why you're sending it. You don't know what it is. It's an unknown substance. So it's legal to mail it. But once you know that it's illicit drugs, it's not legal to mail it. So they don't send you your drugs back. They only want a little bit though, so don't send them a lot. The data from all those samples is publicly available and it's geolocated. So you can see what kinds of samples are being sent in your area and what kinds of drugs, that are being sold as fentanyl or ecstasy or methamphetamine, what's actually in those capsules and powders and tablets that people are ingesting. They also mentioned a few other resources to get data on novel psychoactive substances, and I'll put links to those in the show notes. They were called Toxic and Caesar were the two other websites that you could go to. What did you think of that talk, John?
I thought it was really interesting. It was almost like overload of resources. I did say a couple of things I wanted to pull out of that is I thought that, they were very optimistic that there's a CDC dashboard coming that they're going to have, that maybe this information will be easier for us all to access. And the average doc is pretty comfortable with the CDC website. These other ones are very almost toxicology or pathology specific. And I actually like the banter the best from all the toxicologists about a couple of kind of misinformation points that like really just kind of bugged them. And I'll go over them if you have 2 seconds. One is they were really kind of irked by this idea that kind of touching someone that has fentanyl can result in overdose or kind of a significant illness to a first responder police officer. They basically talked that that's kind of a myth from the toxicology literature. They talked about the idea that in the fentanyl era, naloxone is not effective to reverse fentanyl. And they say that's not true as well. Although they do say that patients that do have overdose with fentanyl, they're more likely to have hypercarbia as well. So that you basically have to treat that in addition to the respiratory suppression. And then the other two that come up in the clinic all the time are fentanyl-contaminated cannabis and cocaine-contaminated cannabis, how those are really not kind of sample analytics that they find. So they don't find that as a very common items that where people kind of mix those two products together. So I hear that a lot of times in a unexplained urine drug screen result that a patient, used marijuana that someone else gave them. And they said that really just doesn't reflect kind of the sample analysis. So kind of some good takeaway points for me.
There's definitely a lot of talk about this concept that just by touching fentanyl, you can overdose, and even trying to prosecute people for malicious assault by somehow letting other people touch their fentanyl. There's a lot of videos circulating on social media of law enforcement, first responders touching fentanyl or touching something that's fentanyl and immediately kind of passing out or shaking or having some sort of reaction. It's really just not how fentanyl works. I mean, as we know, with all our patients, they're all touching fentanyl all the time. People are touching fentanyl. People take fentanyl as prescribed. They touch that. It doesn't absorb, through the skin on casual touch. And so all of this fear of touching fentanyl and overdosing just by being in contact is just another factor that makes it a little harder and a little scarier to care for patients with opiate use disorder.
Well, that kind of wraps up kind of what we got out of ASAM. There's so much more stuff here, so I'm sure we didn't do justice to all the speakers, but it was a really great conference overall, and I really enjoyed all the conversation with all the other addiction med docs.
Yeah, it was really fun. I do have a few talkback comments. I did send a query to our Facebook group about what our listeners might have learned at ASAM if they wanted to share it on the podcast. And one particular friend of the podcast, Dr. Randy Gilo, said this is what he learned, that one, best agents for insomnia for those with opiate use disorder include CBT, not practiced much, but would be great to include in many treatment program curriculum to reduce the number of prescribed meds on discharge. Number two, buprenorphine for pain is effective and safe, like we had said, but you need 3 or 4 times a day dosing to provide pain relief every 6 to 8 hours. And he also was surprised, like you, at the 40% bioavailability if the buprenorphine is swallowed versus being given sublingually or buccally. Number 3, harm reduction is key for many people because abstinence is not possible or plausible. And I'll add, sometimes abstinence is not desirable for our patients. They don't want that. They just want control. They don't want abstinence. And finally, he said low-dose inductions work very effectively, so don't be afraid to try.
Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on Twitter, Facebook, YouTube, Spotify, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy. Audio editing by Aaron McHugh. Video production by Spencer Kennedy. Produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.